Hi everyone, I'm Alison Bray, a pre-registration clinical scientist from Newcastle upon Tyne Hospital's NHS Foundation Trust. This is a presentation about the Primus study, the development of a decision aid for the management of men with urinary symptoms in primary care. We will start recruiting patients into the study in the new year and are looking for GP practices to take part. Primus is a collaboration between these organisations in Newcastle, Cardiff, Birmingham and Bristol. The co-chief investigators are Chris Harding from Newcastle and Adrian Edwards from Cardiff. To start with the background, urinary symptoms in men are hugely prevalent, especially with advancing years. The key to effective management is identifying the most likely cause of symptoms, be it a urological cause such as prostate enlargement, bladder overactivity or a weak bladder, lifestyle and behavioural issues such as excessive fluid intake, or a non-urological condition such as diabetes or heart disease. Some estimates put the number of primary care consultations in the UK for male LUTs at over 1 million per year. NICE claim that around 75% of these men will eventually be referred for specialist care, but that half of those end up being managed conservatively and so could have remained within primary care if GPs had access to the right tools. This culminated in the NIHR releasing a commissioned call in 2015 for their HTA programme to fund the development of a primary care decision-making aid for men with LUTs. We were successful in obtaining this funding, which I'll come back to later. Going back a few years, I was part of a group that developed a device called FlowTaker, originally named P-Pod, which is a portable flow meter and automated voiding diary. It's a single patient use device used by men to record flow rates and voided volumes at home for 1 week. The patient uses the FlowTaker each time they void by placing the jug on top of the sensor, passing urine into the jug and then emptying and rinsing the jug. There are no buttons or switches. Our aim was to address shortcomings of the current specialist assessment for men with LUTs. FlowTaker produces an automated voiding diary, shown on the right, that could replace the current handwritten diary, a poor example of which is shown on the left. NICE in fact recommend that GPs ask men with bothersome LUTs to complete a voiding diary, but our survey research showed that this only happens in between 4 and 18% of cases. We believe this is due to high workload, prioritisation of other tests to exclude serious disease, such as digital rectal examination and PSA, and a lack of support in the training and interpretation of voiding diaries. FlowTaker also provides multiple representative flow rate measurements, shown below, as opposed to just one test carried out in an unnatural hospital environment. In addition, its simple and portable nature makes it ideal for use in primary care. This led us to conduct a pilot study in 2012, involving these 5 practices within the HPCA GP Federation, where 25 men with LUTs were recruited to use the FlowTaker. This was an exploratory study which aimed to investigate the potential benefits of having access to flow and frequency data in primary care. We identified 3 key benefits. First, distinguishing men with likely bladder outlet obstruction, characterised by low flow rates, from those with likely detrusor overactivity, characterised by high flow rates and frequent voiding. Several men had received treatment targeting bladder outlet obstruction, but their FlowTaker data were indicative instead of bladder overactivity. Second, reassuring men with normal results, who then often did not seek further treatment. And third, identifying men with severe disease, for example those with extremely low flow on the verge of urine retention, who could quickly be referred for the specialist treatment they needed. One participating GP said, "The results enabled evidence-based treatment instead of a trial of treatment and improved the patient's quality of life more quickly. They also prevented the need for some referrals." Back to the Primus study, which will aim to develop a diagnostic model based on the results of simple tests that can provide a clinically useful prediction of urodynamic diagnosis. So our gold standard is urodynamics, which is an invasive test where catheters are passed into the patient's bladder and rectum, the bladder filled with water, and bladder pressure and flow rate measured while the patient passes urine. This may sound very unpleasant, but the majority of patients say afterwards that the test was not as bad as they expected. It diagnoses bladder outlet obstruction, diffuser overactivity, and diffuser underactivity. It's possible for a man to have none, 1, 2, or all 3 of these conditions at once. The comparator is a combination of simple index tests, including symptom scores, digital rectal examination, flow taker, bladder diary, and post-void residual ultrasound. All men will have urodynamics and all of the index tests. The benefit to both the patient and the practice is an in-depth assessment of the man's urinary function, including gold standard diagnosis, within a few weeks of joining the study. We will recruit 880 men with LUTs from around 100 GP practices in the Newcastle, Cardiff and Bristol areas in order to obtain 675 complete datasets over a 22-month period, starting hopefully in January. There are exclusion criteria surrounding past invasive treatment to the lower urinary tract, but men already on medications such as alpha blockers or antimuscarinics, but whose symptoms remain bothersome, are eligible to take part. During Phase 1 model development, we'll create 3 statistical models based on the index tests to try and match the diagnosis from urodynamics. During Phase 2 model validation, we'll test the models created in Phase 1 on a different group of men to measure how accurately they diagnose the 3 conditions. In parallel, we'll carry out qualitative work with patients, GPs and urologists to map the diagnoses produced by the models to advice for GPs about how to manage and treat the patient. The decision aid is likely to take the form of a web-based tool where results are typed in by a GP, akin to the Q-Risk tool for cardiovascular disease shown here, and then the likely diagnosis and recommended management displayed on the next page. So, what will practices involved in Primus be asked to do? Invite men with LUTs to take part, identified either opportunistically during a consultation or from regular database searches. Carry out bladder palpation, digital rectal examination and PSA testing for eligibility purposes, or obtain those results from within the last 6 months. We're asking that all men who take part have a GP consultation as part of the study. We'll reassess this and its effect on recruitment at the end of the pilot phase. Take written informed consent from patients, either GPs or research or practice nurses. Administer some of the index tests, including symptoms questionnaires and bladder diaries. Some practices will be asked to provide a room where study activities, including urodynamics, can take place. And finally, follow up patients as usual once they've finished the study. And the study team will do the following: provide all the necessary training, documentation and equipment. Provide the database searches that can be run to identify potential participants. A specially trained nurse will lead the urodynamics investigations. We'll provide per patient payments and also one-off per practice payments for training, etc. We'll produce a report describing the findings from urodynamics and all of the index tests. And best of all, we'll provide Primus pens and post-it notes. So thank you for listening. Finally, I'll leave you with a short video that can be shown in GP waiting rooms, which we hope will help to generate interest in the study. Please contact your research facilitator with any questions or to show an interest in taking part in Primus. We hope to hear from you soon.